Hello, my name is Paul Della Ripa. I'm from the Division of Rheumatology at the Brigham and Women's Hospital. And this lecture will be take-home messages and clinical pearls. By this time, you had seen most, if not all, of the lectures from my colleagues in the Division of Rheumatology. This will serve as somewhat of a summary with some additional points that I'd like to make. These are my disclosures. I'll start with a teaching point based on the physical examination. And the topic is distinguishing bursitis versus arthritis on examination. And the key point is that the ability to fully extend a joint, a knee, for example, with limited flexion indicates the process is outside the joint. The bursa, for example. In bursitis, intrabursal pressure increases with flexion and decreases with extension. In bursitis, full extension of the joint is preserved. Conversely, in an intra-articular process, like arthritis or synovitis in a joint, like a knee, the patient lacks the ability to fully extend the knee because intra-articular pressure increases in extension and is lowest in semiflexion. Here's an example of what I mean. This is the classic swollen knee phenomena. Is it arthritis in the joint, or is it a bursitis above the joint? It makes a difference because these two conditions are different and are treated differently very frequently. So here's a swollen, red, painful knee. Where's the problem? Is it in the knee itself, in the joint, or is it in the prepatellar bursa? So what we did is we asked this patient to flex the knee, and in flexion, the pain increased and the bursa became more tense. Conversely, we asked the patient to fully extend the knee and there was no pain at all, confirming what we had suspected, which was that this was a bursitis and not an intra-articular process or arthritis of the knee. It's very important because if you were considering tapping or aspirating the knee or the bursa, the physical examination guides you onto where to go and which approach to take. This moves us to acute monoarthritis. As you heard earlier, there are many likely causes, including infections such as staph and strep and Neisseria less frequently, crystals such as gout and pseudogout, and then of course systemic rheumatic diseases which present in one joint or start in one joint, such as an RA and in the spondyloarthritis. Trauma or hemarthrosis can do it, and it's important that when you do an aspiration, all the fluid should be analyzed for cell count, culture, and crystals. When you do look at the fluid, it's important to look at the white cells, the number of white cells, to give you an idea of what the type of fluid is and the risk for infection. So as you can see, when the number of WBCs in the fluid is below 200, that is basically normal. And up to 1,000 is essentially non-inflammatory fluid. However, what you can see is that there's a huge range for what constitutes inflammatory fluid and a large range of overlap between what's considered inflammatory fluid and septic arthritis. So you could have a patient with septic arthritis in the 30 or 40,000 range, but that could also be seen in gout or other inflammatory conditions. So there's a large overlap, and there is no exact number which indicates infection or not. And that's the key point to remember. So let's move to gouty arthritis. What are the clinical presentations that are most common? Typically, it's an acute process. It's usually monoarticular or oligoarticular, typically in the lower extremities. The first MTP is involved in 50% of the initial attacks, and 95% of involvement results in recurrent gout in the first MTP. But it's important to note that any joint and tendon in the body lined with synovium may be affected. What about the serum uric acid? It's important to remember that the serum uric acid ranges widely in gout from normal to elevated. So if a patient has a very low serum uric acid, say less than 4, this makes the diagnosis of gout less likely. But it's important to remember that in an acute case of gout, the serum uric acid level may drop 1 to 2 milligrams per deciliter during that acute attack. In managing patients with gout over chronic gout, it's important to know that the goal serum uric acid is 6 milligrams per deciliter or below. What do you do for treatment of gout in the acute situation? In patients where there is no renal failure or risk for ulceration of the GI tract, NSAIDs are reasonable options. Corticosteroids, typically given in tapered oral doses, or intramuscular or IV, can be used. And if there's just one joint involved, then intra-articular steroids are useful as well. Colchicine can be used, but not frequently, up to BID, but it must be used cautiously in renal failure, and then avoid titrating to diarrhea, which was a historical approach to the use of colchicine and is no longer recommended. Other agents such as interleukin blockade, interleukin-1 blockade, and ACTH may be needed in rare cases where either other agents don't work or simply are not tolerated or are contraindicated. What about chronic gout therapy? Allopurinol is the first choice in the vast majority of patients. The buxostat, another agent which is used for chronic gout therapy, is also useful, but there is a black box warning regarding cardiovascular disease in this agent. So in those patients who are at risk or known cardiovascular disease, this agent should be avoided. And probenazid is an effective agent for chronic gout, but it is not useful or effective in patients with ongoing renal failure. Here are the recent recommendations for gout treatment that have just been announced. The strong recommendations include initiation of urate-lowering therapy, such as allopurinol, for all patients with tophaceous gout, radiographic damage due to gout, or frequent gout flares, meaning more than 2 per year. Allopurinol is the preferred first-line agent, and including in that group are moderate to severe chronic kidney disease patients. And so starting at a low dose is recommended, 100 milligrams or less, especially in patients with chronic kidney disease, or less than 40 milligrams in febuxostat if that is being used. The treat to target management strategy is to get the serum uric acid level below 6 milligrams per deciliter. And a newer recommendation is that continuing concomitant anti-inflammatory prophylaxis therapy with low doses of colchicine or other similar agents for up to 6 months is recommended when beginning allopurinol to prevent flares. And finally, HLA-B5801 testing for patients at risk for allopurinol hypersensitivity may be recommended in certain groups of patients who are at risk for that phenomena, as listed here. Another condition similar to gout is pseudogout. This is caused by calcium pyrophosphate crystals. It typically occurs in older adults, and it may typically present as an acute monoarticular arthritis, most commonly at the knee or the shoulder. Remember, if you have pain, swelling, and redness in the toe, big toe, that's typically seen in gout, whereas pseudogout typically occurs in the knee, and it may occur in the shoulder, sometimes in the wrist as well. Patients can develop a mild febrile syndrome, and chondrocalcinosis is commonly seen on X-ray. Here's an example of chondrocalcinosis, this thin calcium line in the knee joint. Remember, this is a radiographic or radiologic diagnosis. Pseudogout is a clinical diagnosis based on the aspiration of crystals, which are noted under polarized microscopy. Acute crystalline arthritis, a review. Uric acid level is not always helpful in acute gout. Distribution of the involvement of the joint involvement may be helpful. Remember, it's important to know that tendon sheaths and bursa may be involved in crystal disease, but it rarely affects central joints such as the sacroiliac joints, the pubis, or the lumbar or cervical discs. It may coexist with septic arthritis or other forms of crystalline arthritis. So patients can have gout and pseudogout, or patients can have gout and septic arthritis concomitantly. And remember, in bad polyarticular crystalline disease, patients can sometimes demonstrate features that resemble sepsis, which include fever. Management of hyperuricemia is often unnecessary in the acute setting, but can be started after initial anti-inflammatory therapy has begun. There are some who advocate for the use of hyperuricemic therapy earlier after the acute setting, and that is an area of ongoing discussion. There are some newer ways to image for gout. Ultrasound can be helpful, which can show what's called a double contrast sign or tophi. And then there's something called the dual energy CT scan, which can show areas of gout in areas of involvement. These are newer techniques and useful in patients where aspiration is either not possible or has not been successful. Let's move to rheumatoid arthritis. In rheumatoid arthritis, in the year 2020, methotrexate is still considered first-line DMARD for most patients. The weekly dose varies from 15 to 25 milligrams, and it can be used orally or subcutaneously. Folic acid or leucovorin are used concomitantly, and regular monitoring of CBC, liver profile, and creatinine are necessary. The goal is to treat to target, which includes frequent monitoring and medication adjustments, which can improve long-term outcomes. It's important to optimize treatment with the current agent, so maximizing its use, for example, using maximum doses of methotrexate before making changes or adding other medications. If initial treatment, such as with methotrexate, is ineffective or not fully effective, then use of other agents concomitantly may be useful. So for example, triple therapy with sulfasalazine, hydroxychloroquine, and methotrexate can be used together and is an effective combination. The use of biologic or synthetic DMARDs, often added to methotrexate, are useful, including TNF inhibitors, which there are multiple versions, IL-6 receptor inhibitors, B-cell deletion agents, T-cell co-stimulatory agents, and oral JAK inhibitors, which have come on the market relatively recently and are given orally. Then, of course, there's the role of steroids. The goal and use of steroids is to keep the patient on the lowest possible dose if they need them at all. There are many side effects to steroids, which you're familiar with, and we try to limit their use by and large. So the take-home messages in rheumatoid arthritis: maximizing the use of methotrexate is still a cornerstone of treatment in RA and may lower mortality in RA based on several studies. Patients who are starting on a DMARD like methotrexate or other agent like leflutamide or any biologic need to have an assessment of hepatitis B and C status, and the assessment of a previous history of tuberculosis is important. All of these patients should be considered for Shingrix vaccination, Pneumovax and Prevnar vaccination, and flu vaccine as well. And it's also important to remember that the use of triple therapy, which includes methotrexate, hydroxychloroquine, and sulfasalazine, are a group of conventional DMARDs which have been shown to be efficacious and cost-effective compared to the use of methotrexate with or without biologic agents in combination, and may have a lower risk of infection. With regard to spondyloarthritis, there are several different types, as you are aware. Psoriatic arthritis, inflammatory bowel disease associated with spondyloarthritis, reactive arthritis, ankylosing spondylitis. In all of these disorders, nonsteroidal anti-inflammatories and DMARDs such as methotrexate are effective, but in patients who have axial involvement, which includes sacroiliitis and spine involvement, biologic agents such as the TNF inhibitors are necessary. Non-biologic agents such as methotrexate do not work for axial disease, and that's important to remember. So if you have a patient with spondyloarthritis and they have back involvement, spine involvement, or sacroiliitis, and that's a problem, then methotrexate and traditional DMARDs are not effective for that. There are a group of newer agents which target IL-17 and IL-12/23, which are now being used in psoriatic arthritis and ankylosing spondylitis, and are especially being used in patients who have not responded to TNF inhibitors as well. We're going to move on and talk a little bit about the ANA or anti-nuclear antibody. This is not a test designed as a screening test. Remember, up to 20% of healthy adults, particularly women, have a low titer ANA and do not go on to develop rheumatic diseases. So there's a high false positivity of this test. And common causes of false positivity of this test include chronic infections like HIV or hepatitis or endocarditis, patients with a family history of rheumatic disease, other autoimmune diseases like thyroid diseases, and as I stated, normal healthy people can have a positive ANA. Once a patient has a positive ANA, it should not be retested unless symptoms change or if there's an increased suspicion for rheumatic disease. Here are some of the antibodies that have been already outlined that can occur in lupus. So the ANA is positive in virtually every patient with systemic lupus. If a patient is ANA negative, the suspicion for lupus drops dramatically, and the risk and association of lupus in a patient with an ANA that is negative is extraordinarily low. So that's an important thing to remember. Virtually every patient with lupus has a positive ANA. Other antibodies may be more specific in lupus, but are, for example, the double-stranded DNA, often associated with disease activity in the kidney. Anti-Smith antibody, very specific for lupus, but the frequency is only 30%. And then a whole variety of other antibodies, which can be seen in lupus, that may be a reflection of skin disease or overlap disease with other symptoms such as arthritis or mixed connective tissue disease, which is a hallmark of the RNP antibody. In terms of antiphospholipid antibodies, the reason to check these is when patients have multiple early miscarriages, thrombocytopenia, stroke or TIA in a younger patient, DVT or PE that's unprovoked, and in patients with lupus. There are major and minor criteria. It's important to know that patients must have some sort of arterial or venous thrombotic event or recurrent pregnancy losses as listed here, and they must have a positive anticardiolipin antibody, a beta-2 glycoprotein antibody, or a lupus anticoagulant being positive, and it has to be positive twice, 2 separate occasions, 12 weeks apart. If someone has a positive test only once and then it's negative thereafter, that laboratory criteria does not meet the normal criteria for the antiphospholipid antibody syndrome. So it's important that there be 2 successive tests that are positive in this regard. Who should be evaluated for antiphospholipid antibodies? Generally, lupus patients are, because they tend to have antiphospholipid antibodies frequently and are at a higher risk for developing antiphospholipid antibody syndrome. Patients under 40 with a CVA, MI, or no obvious risk factor for these things. Patients with recurrent venous or arterial clots. Women with recurrent first trimester pregnancy losses or a second trimester loss. Some advocate for the use of prophylactic aspirin therapy in those with positive antibodies. This therapy has not been shown to decrease the risk of clotting events, except in patients with coexisting lupus. Let's talk for a moment about Raynaud's phenomena. Primary Raynaud's phenomena typically occurs in young women, typically in their teens or 20s. They may have a strong family history of Raynaud's, and they're typically ANA negative. These patients are less likely to go on and develop a secondary autoimmune disease like lupus or scleroderma or similar. However, if a patient develops Raynaud's as an adult, especially after the age of 35, these patients are at a high risk for the development of rheumatic syndrome, and this is termed secondary Raynaud's. The presence of digital ulcers, pitting scars in the fingers, and abnormal capillary microscopy, and the presence of the ANA or other antibodies suggest that these patients are at a high risk or have developed an underlying rheumatic syndrome. So if you do see someone who has Raynaud's and they're an adult, you need to be cognizant of the fact that these patients may or are developing an underlying rheumatic syndrome. And scleroderma being one of them. So the key points with regard to scleroderma, as we heard earlier, is that you need to recognize the presence of concomitant Raynaud's and GERD or heartburn as a possible clinical manifestation of underlying limited scleroderma. And those patients, as has been mentioned before, have a long-term risk for pulmonary hypertension. Interstitial lung disease, or ILD, occurs in diffuse scleroderma more frequently than limited scleroderma, but it can occur in both presentations. It's important to remember that in patients who have scleroderma, one is to avoid high doses of steroids, which can precipitate a renal crisis. Finally, pulmonary hypertension is a complication of long-standing scleroderma, mostly of the limited variant, and there are treatments that improve morbidity and possibly mortality, and they are now available. Newer treatments and clinical trials in scleroderma are underway and are becoming increasingly available. Let's move to the inflammatory myopathies. There are many different types. Typically, they are immune-mediated muscle injury. Usually the CK, creatinine kinase, and aldolase are elevated in most cases. The transaminases may also be elevated. An MRI may show characteristic inflammation, and a muscle biopsy can offer distinctions regarding the actual diagnosis. The typical disorders that we're familiar with are polymyositis and dermatomyositis, overlap myositis, inclusion body myositis, and then immune-mediated necrotizing myositis, which includes those that are related to the use of statins. Here are some teaching phenotypes that you should be familiar with when you're thinking about a patient who might have dermatomyositis. When you're worried about an autoimmune disease, look at the skin and look at the hands, and you'll get a lot of information. So all of these examples are indicative of patients who have dermatomyositis. Here's this erythema around the eye, this malar rash in a patient which looks like lupus but can be seen in dermatomyositis, periungual erythema seen in dermatomyositis, vasculopathic vascular lesions here and here, these little dark spots, which can represent a vasculopathy in dermatomyositis. And then finally, the typical Gautrins papules over the distal surfaces of the MCPs and PIPs, and even in the DIPs of the hands, which are classically seen in dermatomyositis. It's important to remember, though, that there are some patients who have inflammatory myositis where they are amyopathic, or the main manifestations are in the skin or in other organs like the lung, but they don't have active muscle disease or very minimally detectable muscle disease. So if you have a patient who's being treated for an inflammatory myositis, it is also important to remember that if they're not getting better or they're not improving with therapy, with steroids or similar agents, you need to think about whether they have some other type of myositis. And inclusion body myositis is the one you really want to think about. Inclusion body myositis is different because it typically involves distal extremity involvement, such as the thumb, in addition to having proximal muscle weakness, which is common to the other inflammatory myositis or myositis syndromes that we've already mentioned. And it's important to note that a lot of the morbidity and mortality associated with the inflammatory myositis syndromes is related to respiratory complications, including interstitial lung disease. Here's an example of a particular type of myositis syndrome called the Antisynthetase syndrome. The morbidity and mortality associated with this phenomena is mostly linked with lung disease. So these patients get chapped fingers, known as mechanic's hands, and they may get other protein manifestations, which include fever, Raynaud's, arthritis, and they can sometimes often get myositis, but they get severe interstitial lung disease, which can be the major driving factor in their morbidity. The typical antisynthetase antibody is Jo1, but there are a host of other agents which can be seen in this syndrome as well. Sometimes patients who have myositis can overlap in presentation with fibromyalgia. So the pain associated with fibromyalgia can be in distributions which are similar to what we see in inflammatory myositis. But in myositis, these patients typically have weakness, and it's more notable proximal over distal. And these patients typically have inflammatory markers, which are elevated CK, and abnormal EMG. Patients with fibromyalgia do not typically have elevated inflammatory markers. They do not have elevated muscle enzymes, and they do not have abnormal EMGs as well. A word about the SED rate and CRP. They can help to distinguish inflammatory versus non-inflammatory conditions. However, they're non-specific. It's important to remember that the CRP can be elevated in obesity, and the ESR increases with age. For both the ESR and CRP, there is a correction factor that you can utilize for patients who are older. And then finally, remember that the SED rate or ESR and CRP can be normal early in systemic rheumatic diseases. It will never be diagnostic, but it can sometimes help to support the differential diagnosis. So the SED rate and CRP, while very useful, need to be taken into the clinical context of the patient. Fibromyalgia, a difficult and challenging problem. What to do? The examination is important in terms of specific tender points, as mentioned above. Typically, they're tender to touch around joints, not the joint itself, paraspinal muscles. Sometimes the skin is painful, and there's typically no joint swelling. Labs can be checked, such as the CBC, TSH, SED rate and CRP, CK, and vitamin levels such as vitamin D and B12 to exclude other diagnoses. However, avoid checking the rheumatoid factor or ANA unless there's a clinical reason to utilize those tests. Because as I mentioned, there can be false positive ANAs and even false positive rheumatoid factors in low levels, which can confuse the workup and evaluation and can confuse the patient as well. And it's also be very careful about considering this diagnosis in the elderly. Patients who are very old typically don't develop fibromyalgia in old age, and so we're hesitant to make this diagnosis in the elderly as a de novo diagnosis. There are multiple treatment options, a multidisciplinary approach looking to deal with pain, brain fog, fatigue, and insomnia. Education, sleep interventions are very important, especially in patients who have sleep apnea, exercise programs, cognitive behavioral therapy, and then a host of different medications, if not improving with non-pharmacological treatment. Treatment with FDA-approved agents can have some impact in pain, not dramatic, but they can have some impact with pain. And the benefits of the use of those agents have to be weighed against the risks associated with it as well. Now we're going to move to vasculitis. Let's talk a little bit about ANCA. There are two types that we're concerned about. One is the C-ANCA or cytoplasmic pattern, and the second one is the perinuclear or P-ANCA pattern. There are two antigens that are associated with this that you have to see to call this positive. One is the PR3 and one is the MPO. If you just have a positive ANCA, but you are negative MPO and negative PR3, that is not considered a positive ANCA in and of itself. ANCA-associated vasculitis, clinical and laboratory features include microscopic polyangiitis, which is typically a small vessel necrotizing vasculitis and is associated with the MPO ANCA in greater than 90% of the cases. Granulomatosis with polyangiitis, formerly known as Wegener's, is another small vessel necrotizing vasculitis, typically involving the upper airway, the lungs, and the skin, and can also involve the kidney. This is typically associated with the PR3 ANCA and less frequently the MPO ANCA. There is a lot of overlap between these two diseases. Both of these groups of patients can get what's called the pulmonary renal syndrome, which is diffuse alveolar hemorrhage with glomerulonephritis and renal failure. And the third ANCA-associated disease is what used to be called Churg-Strauss, but is now known as the eosinophilic granulomatosis with polyangiitis. The ANCA, typically in an MPO pattern, is only positive in about 40% of patients, These are patients who typically present with longstanding asthma, hypereosinophilia, and other systemic features, including nerve involvement or cardiac involvement, for example. Let's move to giant cell arteritis. Typically, patients will present with a variety of protein features that you're well aware of. Here's a patient with a tender, swollen temporal artery, which runs just in front of the hairline here, and a exuberant inflammatory infiltrate in the temporal artery itself, which should not normally be present. In times of, specifically with regard to symptoms and signs in giant cell arteritis, you can see here that headache is extremely common, greater than 80% of patients. Constitutional symptoms occur in half or more of patients, such as weight loss, fever, fatigue is a very common problem. And then symptoms like PMR and jaw claudication and scalp tenderness occur in anywhere between 30 and 60% of patients. As you can see down here, patients who develop visual loss is in the 10 to 30% range, but it's important to know that visual loss is a serious and catastrophic problem because it is frequently irreversible. Here are some common approaches to treatment for GCA. Prednisone may be used by itself. Prednisone may be used with tocilizumab, which is now FDA approved in GCA. This effort is meant to decrease the prednisone more quickly and to limit the total dose in a shorter period of time. Otherwise, patients may sometimes use prednisone as a sole agent, and if they run into problems or they can't taper, then tocilizumab could then be added for a steroid-sparing effect. The use of methotrexate is of some controversy. Whether it is an effective steroid-sparing agent is unclear, but it may be another alternative in patients who have trouble getting off of prednisone or who need an additional agent. Polymyalgia rheumatica typically looks like an inflammatory arthritis, typically involving the shoulders, the neck, the hip, and buttocks region. It is typically negative for rheumatoid and CCP antibodies. There's no specific lab or imaging for this. It's mostly inflammation, but it is an inflammatory process. It typically involves the shoulders bilaterally. Hip girdle and neck can also occur. Peripheral arthritis, like a hand, for example, can occur in about 10% of patients. But it's important to remember that if someone has peripheral arthritis without shoulder pain, that is not PMR. And a lot of these patients have constitutional symptoms like fatigue, maybe like weight loss, even low-grade fevers at times. Common approaches to PMR include the use of prednisone, starting at 10 to 20 milligrams daily, and then tapering slowly for up to a year or more. And then the alternatives are to use a steroid-sparing agent at some point, including methotrexate or other agents in patients who have trouble tapering off of steroids despite their use. Remember, starting doses of prednisone are typically 10 to 25. Most patients don't need more than 20. The goal is to find the lowest effective dose and then taper slowly thereafter. Therapy can last between 1 and 2 years, as mentioned before. And that is the end of our discussion on our review of our topics today and our clinical pearls. Thank you.